the title of our invention is Non-Invasive Treatment Decision Support for Non-Small Cell Lung Cancer using PET-CT radiomics. And this is an invention by myself, Robert Gillies, Wei Mu, and Matt Shabath. Currently, NCCN guidelines take a patient with advanced non-small cell lung cancer, they do a biopsy, they test the biopsy for EGFR mutation status. They are mutated, then they get treated with the tyrosine kinase inhibitor. If they're not mutated, they'll check for PD-L1 status, and if that's positive, then they can be treated with ICI or immune checkpoint inhibitor. And if they're negative for both, then they just get treated with chemotherapy. The problem with this is that there's a potential for morbidity for lung biopsies. It may fail due to insufficient quantity or quality of tissues, and results can take weeks. We hypothesize that PD-L1 and EGFR can affect tumor metabolism, and FDG-PET is a measure of metabolism. So we hypothesize that FDG-PET can be used to predict PD-L1 or EGFR status. To test this, we built a deep learning model wherein the input are the FDG PET scans from patients that are known whether they are EGFR positive or negative or PD-L1 positive or negative. And we build these deep learning scores. We build two different scores, one for EGFR and one for PD-L1. We've been able to show that these are very stable. This is an example of EGFR. It doesn't matter how big or small your input image is, we still arrive at the same answer. And it doesn't matter what radiologist is doing the initiation, you still get the same answer. At the end of the day, when we built these models, what we've been able to show is that if you determine PD-L1 status from FDG PET, it is indistinguishable from biopsy-determined PD-L1. If you determine EGFR status by deep learning score, it's indistinguishable from biopsy-generated EGFR status. So hence, we believe that this deep learning score can substitute for these invasive procedures. We've got areas under the receiver operator characteristic curves from 0.82 to 0.89 in training, validation, and test cohorts, multi-institutional. In EGFR, we got AUROCs from 0.81 to 0.86 in training, validation, and external institution test cohorts. So we believe this will be useful as a clinical decision support tool pending larger prospective trials. And so our envision is we'll switch from the NCCN to a radiomic guideline where we can use these scores to guide treatment. The next steps for this deep learning score is to add ALK, which is also an actionable mutation, predict severe adverse events, and then test all of this in a prospective trial. Thank you very much.